সুস্মিতা অন্য কম্পিউটার থেকে চেষ্টা করছে।
Okay.
A very good evening to all. I cordially welcome you to the 6th session of Pulmocon 2021. The topic today we will discuss is about spectrum of COVID-19, a case-based approach. To chair the session, I cordially invite Dr. Subhasish Ghosh. Dr. Ghosh is a renowned pulmonologist with a vast experience of more than 30 years. He is an active member of Indian Medical Association, Indian Chest Society, European Respiratory Society, American College of Chest Physician, and Indian Association of Bronchoscopy. He has numerous publications in national and international platforms. His primary area of interest are chronic respiratory diseases, bronchoscopy, sleep studies, and non-invasive ventilation. He is currently associated with AMRI Dhakuria and Apollo Clinic, Salt Lake, Kolkata. I welcome you, sir, and I request you to proceed over the session. Thank you.
Thank you very much. I think we should quickly start. And our first speaker, now the topic is extremely, everybody's hear me?
Yes.
Okay. So I think I must congratulate Dr. Pathophysiology Bhattacharya for choosing such a topic, such a time, since we are going through still the ravages of COVID. And with me are two excellent speakers. And the first speaker is Dr. Roychowdhury, who doesn't need any introduction, but still I'm going to go through this. He's a passionate teacher, researcher, and an avid academician. He has more than 27 years of experience in pulmonology, critical care management, and interventional pulmonology. His areas of expertise: orphan lung disease, interstitial lung disease, asthma and allergy, COPD, interventional and diagnostic pulmonology, and all disciplines of respiratory medicine. He has been an active in drawing national guidelines on pneumonia, COPD, spirometry, and bronchoscopy under Indian Chest Society, and also in drawing ILD Indian guidelines under ICS and NCCP. He remained a member of the governing body of the ICS and has a major role in developing modules in ICS curriculum. And of course, he has published several papers in peer-reviewed international journals, including Embark study from India. Now, Dr. Dhar is going to talk on acute COVID and the spectrum of acute COVID case-based approach. And this is likely going to be a lot of take-home messages. Without wasting any more time, let's move on to Dr. Roychowdhury. Dr. Dhar. I can't hear Raya.
Hello.
Yeah.
Hello, friends. Good evening, and it's a pleasure to be here with you today. I want to thank Dr. Pathophysiology Bhattacharya, Parthoda, for inviting me to speak here. What I'm going to do over the next half an hour is to talk to you about 4 different clinical scenarios in COVID. Each of these scenarios have certain messages which I want to convey to the audience. Hopefully, these messages would help us in preparing ourselves for the 3rd wave and beyond when we see COVID cases. So the first case I want to talk to you about is a case of mild COVID. These are all real life cases. There's one case which I won't mention separately, but which is myself when I had COVID. But this is a 50-year-old consultant physician who worked in a tertiary care hospital and was involved in the management of COVID-19 patients. He presented with a dry cough and a high-grade fever of 104 degrees Fahrenheit. The fever came when he was actually working on a COVID ward. He went and isolated himself. The fever got worse and he got admitted to hospital. He had no other significant complaints. However, comorbidity-wise, he had diabetes, which was fairly well controlled with the last HbA1c of 6.8, which was done about 3 months ago. On admission, his saturations were fine. He was tachycardic. which was commensurate with a temperature of 102 degrees Fahrenheit, and he was hemodynamically stable. Auscultation of the chest showed clear chest with good going breath sounds. A day later, the RT-PCR result came back as being positive. The CT value was low at about 17. The chest X-ray and the CT scan, which I'll show you in a minute, gave an impression of a right lower lobe opacity. The CT showed ground glass opacities. Let me show you the CT first, and then I'll show you the blood reports which were done on admission. So that's the CT, and all of you would identify this small area of ground glass opacity, which is that there at the right lower lobe. You tend to over-investigate with doctors, and that's what happened with this gentleman. 4 days, 5 days down the line, he had a second CT scan, which was similar, just that the area of ground glass opacity had become more dense, which is something you would expect. So nothing very much. A score of 1 out of 25 was what was there on the CT. The only point of concern was the high fever. These are the blood results, which were reasonably reassuring. You can see a CRP of 26. The hospital in which the gentleman got admitted and where he worked had a CRP level of less than 0.3 as being normal. The other parameters checked have all been important parameters in prognosticating for COVID, not for mild disease, but for patients who get admitted to hospital. And they are within reasonably normal limits. The IL-6 of 62 does not carry much of a significance. It just shows that there is an inflammatory process in the form of the COVID-19 ILI, which was ongoing at that point of time. The doctor was started on an oral antiviral. Favipiravir was started. He was given a combination of doxycycline and ivermectin, which was the in treatment at the time. He was given vitamins, zinc, vitamin D3 and C. He was given prophylactic enoxaparin, and then a D-dimer, which went up to 2000 on repeating, mandated that the enoxaparin was changed to therapeutic at 60 units twice a day of enoxaparin. The fever subsided after day 4 of admission. He kept doing his own 6-minute walk test, and it never showed any desaturation. A repeat CT about a month down the line showed resolution of the opacity, and the IL-6 came down from about 60 to 16. Let's discuss a few questions. That's an easy case. That's a case that all of you would have seen on a day-to-day basis. But a few pointers. We don't want to criticize the treatment. This wasn't me managing this patient, but I'm not trying to criticize the management. What we're trying to do is to discuss pertinent points so that going forward, we manage these patients better. The first question was about the cycle threshold and whether the cycle threshold should determine whether we use favipiravir or remdesivir as being the antiviral. This is the question that I've often been asked, especially by my colleagues, and hence this mandates an answer. So the cycle threshold does not really correspond to COVID severity. So you've seen patients who got a high cycle threshold, hence a low viral load, but quite a severe pneumonia, which has resulted in hypoxia and intensive care management. On the other hand, like in this gentleman, you might have someone with a low CT value, hence a high viral load, and that does not necessarily correspond to a bad COVID pneumonia. Hence, the use of an antiviral in this scenario is something that can be questioned. There is absolutely no indication of giving remdesivir in this situation. There have been enough trials, there's been enough data generated to show that use of remdesivir should be restricted to patients at the onset of hypoxia or just when they start using oxygen, if it needs to be used at all. The data about favipiravir is not very robust, and hence you can question the use of an antiviral at this juncture. Till the time we have better antivirals, and I'll come back to that in a minute. What about HCQS and ivermectin? So this case is from the ivermectin HCQS era. This is from the time when HCQS used to be the only drug. So we're talking about 2020 May when this case happened. So now we know that there's absolutely no rationale for using HCQS in COVID-19 or chloroquine for that matter, and the fact that you actually do more damage than good by using HCQS. What about ivermectin? So there's been a meta-analysis with ivermectin which shows that in patients with mild to moderate COVID, using ivermectin can reduce the duration of the disease process and reduce viral replication. It's not robust data. I'm not a great fan of ivermectin and have hardly used it at all during the pandemic. However, there's a little bit of scientific rationale. There's a little bit of data now available to support the use of ivermectin in a class of patients who have mild COVID. What about prognostic markers? So I would frown on doing prognostic markers in patients who do not get admitted to hospital. The role of prognostic markers in mild COVID is questionable. When this case happened, patients used to get admitted even with mild COVID. This is no longer the case. In the second wave, we had so many cases that even patients with severe COVID often couldn't find a hospital bed. Hence, mild COVID patients remained at home. You will continue to have patients with mild COVID going forward because most of the population will gradually get vaccinated and hopefully will only get mild COVID infections. Is there any use in doing prognostic markers in these patients? The answer is no. Your IL-6, your D-dimer, your lymphopenia, etc., have no value at all in mild COVID. And I would recommend that you do not do these for mild disease, only reserve them if the patient is getting worse or have moderate to severe COVID infection at the time of diagnosis. Would you use steroids? You would never want to do that. This is not the patient for steroids. This patient isn't hypoxic. This patient isn't spiking temperatures post day 7 of onset of disease. The patient does not have a very high score, CT score, at the time when the patient has a CT done. So you would do a great amount of harm by increasing viral replication and hence push the patient into more severe disease if you gave steroids to these patients. What about using an anti-IL-6? Again, big no. Thankfully, not many people with the disease process this doctor had would actually get prescribed an anti-IL-6. However, I think it's important to understand that IL-6, doing an IL-6 in this case defeats your purpose because you're never going to prescribe an anti-IL-6 or a monoclonal antibody in these disease processes. Would you want to repeat a CT in 4 to 6 weeks' time? Probably not. This doctor got a repeat CT done, but then he was a doctor. He had easy access. I wouldn't recommend my patients with such mild disease have repeat CTs because you would almost be sure that the CT would return to normal in these individuals, given the low severity score in these patients. So this I said was from April, May 2020. We now have newer options for mild disease, and let's dwell for 2 or 3 minutes on these newer options. And I want to bring to focus 3 different agents, which I argue would be your treatment of choice going forward with mild disease. So inhaled budesonide, tablet molnupiravir, and the antibody cocktail. So in no definite order, I'll speak to you for the next 2 or 3 minutes about these 3 agents. The Oxford study, called the STOIC study, looks at steroids in COVID-19. This is from Lancet Respiratory Medicine. It comes from the house of Dr. Mona Bafadel, a very good friend. We are actually proud to have just completed STOIC 2, a study of a similar design being done in India, and we are collating the statistics for this study. So this looked at inhaled budesonide in COVID-19, and we're talking about mild or moderate disease. The reasons used inhaled corticosteroids I've summarized. I've not gone into details of the trial, but these are some carry-home messages for all of you. There's relative reduction of 91% on COVID-19 urgent care visits and emergency department visits and hospitalization. Clinical recovery is 1 day shorter. The mean proportion of days with fever in the first 14 days was lower in the budesonide group. The median proportion of total days that participants required as needed antipyretics was lower in the budesonide group. Fewer participants randomly designed to budesonide had persistent symptoms at day 14. There was reduction in symptom burden. However, there was no difference in saturation between the 2 groups, and there was no difference in viral load. So remember what you're doing. The most important endpoint The reason why you prescribe inhaled steroids to your patients is a relative reduction of 91% on COVID-19 related urgent care visits, emergency department visits, and hospitalization. And that, I think, is enough rationale for prescribing the drug. The All India Institute of Medical Sciences, post the STOIC trial, thankfully recommended it for our Indian patients. However, the one bottom line which appears in the guideline, which probably needs changing, is there for you to see. It says inhalational budesonide at a dose of 800 micrograms twice a day for 5 to 7 days to be given if symptoms are persistent beyond 5 days of disease onset. So the one which probably needs changing is beyond 5 days of disease onset, because with all these drugs, especially with inhalational budesonide, you want to be prescribing the drug as early as possible rather than waiting for 5 days before you prescribe. So the drug is fine, the dose is fine. My message to all of you is to prescribe the inhaled budesonide as soon as you manage to diagnose the disease. The earlier in the disease process, the better is going to be the response. The next drug I want to talk to you about is the antibody cocktail, something which all of you would have heard about, maybe prescribed, and the drug which seems to have the greatest amount of evidence in mild to moderate COVID. So what's the antibody cocktail? It's a combination of two monoclonal antibodies, casirivimab and imdevimab, which bind non-competitively to the COVID-19 virus cell surface, and hence prevents the virus from infecting healthy cells. The recommendation is for the treatment of mild to moderate COVID-19 in adult and pediatric patients, and we are talking about children 12 years and above and patients with a body weight of more than 40 kilos. The drug seems to work the best in patients who do not require oxygen, and it seems to work the best in patients who have comorbidities. When we talk about comorbidities, it's diabetes, uncontrolled hypertension, chronic kidney disease, COPD, etc., but the drug seems to work the best. The dose is there for you to see, and the evidence summary is at the bottom. Let me use the cursor to point out some important benefits for you. So the phase 3 trial looking at outpatient visits on the left on there showed that in a double-blind RCT, there was significant reduction in risk of hospitalization in similar lines to what I described with inhaled budesonide. The next one, the most exciting one in my mind, is the phase 3 post-exposure prophylactic study. So this is patients who have asymptomatic disease and have come in close contact with a COVID-19 index case. So post-exposure prophylaxis patient, it showed a significant reduction in symptomatic RT-PCR confirmed infection by a whopping 81.4%. Then there's the trial that everyone quotes, the recovery trial, which is hospitalized patients with COVID-19. And this showed a reduction in mortality at 28 days, 24% versus 30% with a P of 0.001 in the antibody cocktail group as compared to the placebo group. Then you have the hospitalized patient data, which is a double-blinded RCT, where patients were entered with no supplemental oxygen and low flow oxygen. And again, there was reduction in viral load within 7 days of treatment in patients with seronegative. So patients who were RT-PCR negative on low flow or no supplemental oxygen. So that's the first data coming in about patients who are suspected on the basis of clinical features and CT scan, but with a negative RT-PCR report. In the last group, there's an in vitro study which has shown that it maintains its susceptibility against the Delta and the Delta plus variants. So that's about the evidence summary. Let me summarize the group of patients where you would want to give the antibody cocktail. So it's effective in treatment of mild to moderate COVID-19 and reduce hospitalization and mortality by a large percentage, 70%. Susceptibility against the new mutant strains, Delta, Delta plus, and one would hope that the susceptibility will also be there against the new strains that will keep coming in. Recent approval for post-exposure prophylaxis makes it a very exciting drug. and it might be a useful drug in patients who are seronegative and hospitalized due to COVID-19. The third drug which could have been used for this doctor, so we've talked about inhaled budesonide, which could have been used. We've talked about the antibody cocktail. The last drug is molnupiravir, which is a drug which was originally described for the management and treatment of influenza. We know that this has got broad spectrum activity against coronaviruses, even the SARS-1, the MERS, and the COVID-19 virus that we are discussing today. I want you to look at the results of the phase 3 study right at the bottom of that page, which says that molnupiravir reduced the risk of hospitalization or death by approximately 50%. So that's better data, the best data that we've had for any antiviral till date. This is the summary of the evidence we have, the fact that it shows activity in vitro and in animal studies. The phase 1 and phase 2 studies have shown favorable result. The phase 3 interim analysis, based on which we are hoping that there would be an approval for this drug, both in India and outside, showed 50% reduction in the risk of hospitalization and mortality. So treatment of mild to moderate COVID-19, those at risk of progression, and partially vaccinated, those with both doses of vaccine will probably be effective on this drug. Post-exposure prophylaxis studies have also been done with molnupiravir, like the antibody cocktail, but the results are still awaited. So this is the first half. I've taken a while to describe the first case because I wanted you to go through the data for drugs which you are likely to use going forward in the COVID-19 pandemic. Let me take you to case 2, and we'll have case 3 and case 4, which discusses various other facets. So this is another doctor of the same age. And again, let me clarify that these are not made up stories. They're actually true. So this again works in a, should read tertiary care hospital, not tertiary care. So tertiary care hospital who's involved in the management of patients with COVID-19. Again, dry cough, high fever. Patient is diabetic again. Saturations of 96% and a temperature of 102. Identical clinical picture to the previous patient. Again, RT-PCR positive with a high viral load. However, this patient has much greater opacities on the chest X-ray and the CT scan. So right lower lobe opacity, let me show you the CT, and you would appreciate that there's areas of consolidation at both bases of the lung. And you can see ground glass opacities almost in every lobe of the lung. Again, this patient was started on favipiravir, doxycycline, and ivermectin. Enoxaparin was given to this patient. Patient was much better, and discharge was being planned for this patient if he remained asymptomatic. However, unlike the first patient who became better and went home, this doctor on day 7 spiked the temperature again of 102. With the spike of temperature, he desaturated to 84% in room air and 96% on 3 liters of oxygen with a nasal cannula. He was tachypnic with a respiratory rate of 28 per minute, coarse crackles in both base. The patient with this desaturation got transferred to COVID RCU. The consolidation on chest X-ray looked worse when repeated 48 hours down the line. This patient, as you can see, has a high white cell count, a high CRP, a D-dimer, which is about 2,500, a procal, which is significantly raised, and IL-6, which is raised. So all these parameters, these prognostic markers are important here. Unlike the first case, which was much milder disease, the fact that this patient has a total count, we don't have relative lymphopenia here. Unfortunately, we should have had done. But the fact that the patient has a raised LDH, a raised D-dimer, a raised procal, a raised CRP, indicate that this is more severe disease with a likely graver prognosis. The possibilities here, when this patient spiked the temperature on day 7 to day 8, are there in front of you. And I want you to remember these because these are factors that you need to think of when your patient gets worse between day 7 to day 14. The most likely cause that we have all seen by far is a cytokine storm. The next commonest factor is a secondary infection. However, thromboembolic disease can also give you a fever. So it's not as if it's hypoxia alone you think of thromboembolic disease. even with fever and hypoxia, you think thromboembolic disease. And then heart failure from COVID myocarditis is another disease process that you can think of. So cytokine storm, secondary infection, thromboembolic disease, and multi-organ involvement, especially in the form of COVID myocarditis and heart failure, are things that you think of when patients worsen like this doctor worsen. And this is the repeat CT scan done on day 10 from onset of infection, from onset of symptoms. And you can see the dense consolidation in both lower lobes. This is lobar consolidation, looks like a lobar pneumonia. So antibiotics were escalated in this patient. IV meropenem and teicoplanin was started. A sputum was sent on for culture. The patient was started on steroids. The dose used was 60 milligram twice a day. The patient with a D-dimer of 2,500 was started on a therapeutic dose of enoxaparin, and supportive medications were given. The sputum on gram stain showed gram-positive Diplococcus. The sputum culture showed pan-sensitive strep pneumonia. So this patient had a secondary infection, or maybe a co-infection we did not look earlier, with strep pneumonia. So when we got strep pneumonia, the antibiotics got de-escalated to IV coamoxiclav. We said this was a pan-sensitive strep pneumonia. So de-escalated to IV coamoxiclav. Methylpred was given for a period of about 3 days IV when the patient was sick, and then changed to dexamethasone 6 milligram once a day orally. So questions that arise here: much higher viral load here. Would you, on hindsight, have started this patient on remdesivir rather than favi? I would argue not. I think this patient, when favipiravir got started, was eligible for favi, wasn't eligible for remdesivir. He desaturated because of secondary infection, which we found out appropriately and treated appropriately. What about HCQS and ivermectin? We've said this before. This combination probably was not mandated in this doctor, and I wouldn't repeat it in this patient if I had a similar patient again. Do you think initial management would have been different? So maybe not the doxy and ivermectin, but I think I wouldn't treat this patient any differently if they came with the presentation that they had initially. What about empiric antibiotics? I think empiric antibiotics should be given in patients who have a very raised CRP or a raised procal at onset. If these patients have what looks more like a consolidation rather than GGO, if these patients spike a disproportionately high fever or have a productive cough with purulent sputum, those would be my indications of giving empiric antibiotics. This shows you an important slide. This shows you the incidence of co-infections and secondary infections in patients with COVID-19. This study dates back to about July 2020. The numbers haven't changed very much. They say 3.5% of co-infections on presentation. So that's COVID-19 plus another infection happening simultaneously, and about 15% patients with a secondary infection after presentation. So that's a total of about 18% of your patients. However, antibiotics get prescribed in COVID-19 in about 72% of cases. So 18% infected cases, 72% antibiotics. That's huge overprescription. And I would request all of you to think before you prescribe antibiotics to your patients with COVID-19. This brings me to my third case. I've got about 7 or 8 minutes. So I'll run past these 2 cases, but they carry important messages for you. I've titled this case as Living with COVID-19. So this is a diabetic, hypertensive, obese lady of 75 who again got admitted in June 2020. She had a fall at home, a trochanteric left fracture, left distal radius fracture, no respiratory symptoms and no fever. However, on direct inquiry, she had multiple bowel evacuations, and she also claimed she had anosmia. This was when you ask these questions to the lady and not voluntarily for talking about these symptoms. She needed the trochanteric femur, left femur fracture and the left radius fracture fixed. So she had the screening RT-PCR test done, which came back as being positive. The result came as you see on the 9th of June. The chest X-ray showed a bit of haziness on the left lower zone, but it wasn't like COVID. She was obese, so a bit of haziness on a chest X-ray was difficult to interpret. The blood results were fine, good lymphocyte count, low D-dimer and LDH, which was reasonably normal. On the 12th, however, this lady developed a cough with sputum and shortness of breath. She developed oxygen requirement, 2 liters oxygen, saturations of 94%, and the chest X-ray showed increased density in the right lower lobe, what was thought to be a right lower lobe collapse. Given these new symptoms, the patient had the COVID RT-PCR repeated on the 15th and 17th, and both of them came back as being negative. So this is the right lower lobe in this individual on the subsequent chest X-ray. So we did a BAL in this patient. The patient was an inpatient in hospital, unwell, multiple comorbidities, COVID negative. We did a BAL. The sputum got cleared. We sent the sputum for culture. The culture showed Klebsiella pneumoniae. We treated the infection appropriately. She had a trochanteric fracture reduction done on the 21st, and she went home reasonably well on the 23rd. However, this lady was unlucky. About 10 days down the line, she got readmitted again, unwell, very unwell, dyspneic, drowsy, with generalized swelling. She was very hypoxic on presentation, 6 liters of oxygen with the face mask, saturating at 87%. And this time she had large bilateral low lobe consolidation with a left-sided effusion. She continued to worsen. On admission, she had a COVID-19 test done, and this was a positive test. Remember from the previous slide that this lady had a trochanteric fracture fixed with a COVID-19 result which was negative on the 15th and on the 17th. So this was a new positive COVID-19 report. The prognostic markers are there for you to see. You can see the reports are worse this time. She has lymphopenia with lymphocyte count of 15%, a very raised CRP, an LDH which is far higher than before, and a D-dimer of 6,200, a procal which is significantly raised. And you can see that these X-rays look horrid, horrible looking X-rays. You can see the chest drain on the left side. This was to drain the parapneumonic effusion. So putting things in perspective, elderly lady, multiple comorbidities, a trochanteric fracture, COVID positive incidentally, then with symptoms, 2 RT-PCRs negative 48 hours apart, a BAL which was RT-PCR negative on the first occasion. The patient returns with RT-PCR positive after 8 days. This is what I would argue is a likely recurrence of COVID, and there's no facility for antibody testing at the time when this case happened. You remember this was in June 2020, where we did not have access to antibody testing. So for this lady, given her frailty and general condition, the family decided not to go for further escalation. A palliative approach was adopted, and it was decided not to intubate and ventilate this lady. And unfortunately, she passed away peacefully on the 15th of July, 2020. So this was what I would describe as a COVID recurrence. I say this is a recurrence confidently because a bile RT-PCR, which has got a 99% sensitivity, came back as negative for this lady, and a subsequent nasopharyngeal swab was positive. So this is a Chinese study which showed a 14.5% positivity post-discharge of COVID-19 patients. So COVID negative at the time of discharge, 2 different samples, and later an RT-PCR positive. There are patients with 2 consecutive false negative RT-PCR reports who have a significantly longer nucleic acid conversion time, 36 days versus 21 days as described in this study. How are you sure? How would you absolutely clarify that this is not the same infection but a recurrence? The only way to do that would be to do a genetic characterization of the virus, something we clinicians don't have easy access to. So we can only say with reasonable certainty that this is a recurrence versus a recrudescence of previous infection. There's a French group which described itself as the Collaborative Study of COVID Recurrences, the COCOREC group, smart sounding name, where they talked about second confirmed COVID-19 episode at least 21 days after onset. They looked at patients between the 6th of April and the 14th of May. The median duration of symptoms was 18 days for the first episode and 10 days for the second one for the 7 patients who eventually recovered. All the patients had a positive RT-PCR in the respiratory sample from both episodes. These describes the 12 to 11 patients, and I want to be quick with this for the sake of time. So 4 healthcare workers, 3 recovered quite quickly and came back to work. 1 had more severe symptoms but came back to work nonetheless after about a month. 7 older comorbid patients with a median age of 73, not very different to the patient I have just described, who required acute care hospitalization for both episodes. They had clinical recovery at 11 days of interval. And during the first episode, 1 patient, this was June 2020, so received lopinavir, and 3 received corticosteroids. They required oxygen therapy. 2 of the patients in this group died of ARDS recurrence and 1 of right heart failure. So patients with recrudescent infection, especially if they're elderly, especially if they have comorbidities, very much like severe COVID infections, can actually die from getting the disease with a significant mortality rate. That's what the French group talks about. So carry home message from this group. If someone has had COVID recently, comes back to you, post a negative test, or even without a negative test, think COVID again. It's important because you can treat these patients appropriately. Skip this slide and talk about the last case in the last 2 to 3 minutes. This I have titled as to be or not to be COVID-19 pneumonia. So this was a 36-year-old lady, diabetic again on insulin, otherwise fit and well, played tennis on a regular basis. She worked in the corporate sector, fit and well, smart young lady, fever, moderate, maximum temperature of 102 degrees Fahrenheit with a dry hacking cough for the last 10 days prior to admission. She went to the local GP who requested an RT-PCR. The result of the RT-PCR came back as negative. The GP, smart guy, started her on doxy, ivermectin and vitamins anyway. 2 days later, the family rang the GP because the saturations had started dropping and had gone from 98% at rest to 93% at rest. The GP, bless him, started him on Predmed tablets, 32 milligrams daily, and asked the patient to continue other meds. You would wonder why I said bless him, because this is the time you would advise the patient to go into hospital, not start the patient on oral steroids at home. He did say, make sure you have an oxygen cylinder at home. Again, I would argue that's the wrong thing to do. You would want this patient to go into hospital and get treated with medications which are evidence-based at this point of time. Next 2 days, the patient's saturations remain at the same level. She still shouldn't say he, should say she. She felt a little breathless on exertion. Temperature spiked to 102. She kept feeling increasingly unwell. And now she has diarrhea and crampy pain abdomen. She arrives to the hospital, I would argue, late. Day 10 from onset of symptoms. She's unwell at the time. Saturations of 84% on room air, 94% on 4 liters of oxygen, respiratory rate of 26 per minute, tachycardic with a heart rate of 116, and febrile with a temperature of 103.4. The patient has an RT-PCR sent again, which is negative, does an HRCT, which is suggestive of COVID pneumonia. So CT, want you to have a look at that CT once. So you can see the dense areas of consolidation. This shows that the disease is old. It's been a few days. You can still see the upper lobes. Now you see the lingula and the middle lobe. Dense consolidation all the way from the top to the bottom. Let me show that to you once more. Scroll through the CT again. So these are denser shadows. They're everywhere. They look more like consolidation. The reason you don't see ground glass opacities is because this patient is at least 10 days from onset of disease. So let me go forward. So COVID RT-PCR negative, complete blood count The hemoglobin, which is slightly on the lower side. Lymphocyte count is okay. The CRP is high. The D-dimer is middling, so between 500 to 1000. An NT-proBNP of about 1000. A TROP, which is negative. An IL-6, which is significantly raised, but again, probably doesn't mean very much. With 2 or 3 RT-PCRs being negative, we did a BAL because the CT was suggestive of COVID pneumonia, and the BAL showed an RT-PCR positivity with a low CT value. Cultures were negative, AFB was negative. The patient was treated as severe COVID pneumonia. Remdesivir and baricitinib, you would remember this is day 10. So it's almost the cutoff time when you can prescribe an antiviral to these patients. We took a chance because she was young and she came into hospital late. She was given the steroid, she was given a BLBLI, but the antibiotics were stopped at day 3 when the BAL culture came back as negative and she was anticoagulated as per protocol. She recovered well and discharged on day 7. Oxygen requirement went away after day 3 from admission, and she was out of ICU after day 3. So this slide shows you some reasons for a false negative COVID test, which is what this lady had. So if you have a low viral load associated with disease course and disease severity, if you have a sputum or a throat swab sample which is of poor quality, if you have a poorly performing kit, if you have lack of standardized operating procedures, you have poor interpretation of results, and you have quality control issues, all of these can give you false negative results. Studies have shown that if patients have a high platelet count or a CRP level at the beginning, at onset of disease, they have a higher risk of a false negative RT-PCR. Adding an antibody test like we do now helps in diagnosing these patients who have a negative RT-PCR, but everything else suggestive of COVID. Some authors have suggested doing 3 RT-PCRs like was done for this lady. If the suspicion remains strong, do a CT. You can treat patients based on a CT, but there's very little evidence. You can do a BAL in centers where a BAL gets done in these patients, but the healthcare worker needs to take all precautions possible in doing a BAL because, as you know, a bronchoscopy is an aerosol generating procedure which puts patients at high risk. So these are predictors of negative SARS-CoV-2 RT-PCR despite a final diagnosis of COVID-19. So patients who have fatigue, malaise, and headache, and who have a platelet and a CRP, which are positive, these patients might have a false negative test at the beginning. Patients with a false negative RT-PCR for COVID-19. So this is a cohort of patients, about 4,000 medical admissions between March and May 2020, which looked at patients with confirmed COVID-19, presumed COVID-19, and negative for COVID-19. And I want you to highlight on the bottom part, which I'm pointing to with the cursor. You can see the number of deaths in patients with severe COVID-19. Patients who died was far higher in confirmed cases as compared to patients who had presumed COVID-19. Patients who got admitted to ITU was also greater in patients who had confirmed COVID-19 versus patients who had presumed COVID-19. This is our data, which I'll sort of not run through, but looks at about 40 odd patients who had 2 COVID RT-PCR nasopharyngeal swabs negative. So these are patients with RT-PCR negative where we did the BAL, and most patients had a BAL RT-PCR which was positive. So that's my concluding slide. So mild COVID-19 pneumonia has got more evidence-based treatment options now available. Post-exposure prophylaxis is now a possibility. Think of co-infections and secondary infections, they do happen, but don't prescribe blunderbuss antibiotics to everyone. The reinfections can happen. So if your patients with COVID whom you cured come back again with fever and cough and similar symptoms, think COVID again. Don't think that because they've had the disease once, they will not get the disease again. And if clinical features and radiology are indicative, an RT-PCR negative test can be false negative and appropriate measures are required. We go into the third wave now, and I'm sure there'll be more cases going forward. Make sure you look after yourself. Be cautious. There are more evidence-based treatments which are available, but you can only look after your patients if you look after yourself. Be safe. and make sure that you and your patients indulge in COVID-appropriate behavior. Thank you very much for listening, and I'll be very happy to take questions.
Thank you, Raja. That was excellent. And I think you've answered all the questions because you put the questions pretty, all relevant questions. Now, I have just a couple of questions. One is regarding the second case which you had, the one we had a lobar consolidation and responded to antibiotics. Suppose this patient had a GGO, extensive GGO, and the procalcitonin was normal, the total count was normal. Would you have given him an immunomodulator apart from steroids like toci or baricitinib?
Yes, Subhasish, I think given the fact that the inflammatory markers were so high, given the fact that this patient spiked a high temperature, and given the CT changes, we suspected that there could be a secondary infection. Like you rightly pointed out, in the absence of these features, so if the patient just became more and more hypoxic, maybe with a fever which was lower grade, a CT showed ground glass opacities and a procal at a CRP level which was low, as you said, I think a MAB would be an appropriate treatment at the juncture because cytokine storm would be the most likely cause for the worst of the patient's condition as it happened in case 2.
Thank you, Raja. Just another question which you highlighted very, that was one very good, which you mentioned. When do you increase the low molecular heparin to the therapeutic level? I mean, that's
sure.
That's
sure.
very interesting.
Sure. So I think there is a little bit of evidence in this. I mean, there is nowhere that there's a lot of evidence and COVID Subhashishda, but there's a little bit of evidence. And if you look at the Finnish guidelines, the Scandinavian guidelines, if you look at the British guidelines, they propose to increase the from prophylactic therapeutic low molecular weight heparin when the D-dimer goes above 2000. That's the magic cutoff. I don't know where the cutoff comes from, but that's what people have done during the second wave. There's, like I said, it's not a lot of evidence, but that's what we did during the second wave.
Well, there are certain questions here. If the prophylactic dose is increased to therapeutic dose in severely unwell patients, they don't do well. Only the mild and the moderate patients with high D-dimer more than twice does better when you switch to therapeutic.
I mean, that's probably, yeah. So I don't think that's got anything to do with the D-dimer or the low molecular weight heparin.
It's too late, yeah.
We know it's just too late for any intervention, like you said, and
that's right.
Anything to do with the heparin as such.
Right, thank you, Raja. Thank you, excellent, as usual. And we will switch to the next topic. And I have Dr. Sushmita Roychowdhury, another wonderful speaker, who will be talking about the second aspect of COVID, the long COVID, which we are seeing now more commonly than anything else in our OPDs, coming with a lot of symptoms, systemic symptoms, respiratory symptoms, non-respiratory symptoms, and even after 3 months of COVID. So we have Dr. Sushmita Roychowdhury, who's going to talk about long COVID syndrome and post-COVID pulmonary complications. She's the director of pulmonology in Fortis Hospitals, and it'll be Dr. Sushmita Roychowdhury. Dr. Sushmita, please carry on with your presentation. Thank you.
Thank you, Subhashishda. So after Raja's eloquent, nicely presented talk, here I am, a little bit didactic, I think. But just to start, where did this thing about long COVID come? And this was in King's College, London, where one of the epidemiologists said that even though COVID-19 is a mild illness for many, they noted that over 1 in 50, actually people had symptoms persisting beyond 12 weeks. So they felt that while we were worrying about excessive deaths, we also need to consider people who are going to be a burden on the health economy of a country, and also in their day-to-day life are not going to be able to do as much as they did before. And since then, in the last 2 years, we've noticed that people who've had COVID maybe stay in hospital for 5 days, 6 days, 10 days, but they have symptoms persisting beyond 4 weeks, 8 weeks, and 12 weeks also. So long COVID gradually evolved as a name and had many synonyms where we called it long. Then we called it post-COVID-19 condition, post-acute COVID-19 syndrome, post-acute COVID sequelae of SARS-CoV, and long haulers, as they called it. But finally, WHO, to give it a certain name, has come out with a consensus of calling long COVID as a post-COVID-19 condition, where they say that post-COVID-19 condition occurs in individuals of history of probable or confirmed SARS-CoV infection, usually 3 months. So 3 months is where they could get the cutoff to be for long, calling it long COVID, because otherwise acute COVID can persist for a certain time. And common symptoms include fatigue, shortness of breath, cognitive dysfunction, but also others, and generally have an impact on everyday functioning. The symptoms may be new onset following initial recovery from an acute COVID episode or persist from the initial illness itself. So they may get better and then have symptoms. And now again, there will be a question of whether there is recurrence of infection or not. And it is characterized by persistent symptoms and or delayed or long-term complications. So even complications will fall in the long COVID group, not just persistent symptoms. So the categories that they've decided, and this is a very nice paper in Nature, if you have time, do go through it, that in 4 to 12 weeks, it's called subacute or ongoing COVID-19 symptoms, but beyond 12 weeks, chronic or post-COVID-19 syndrome. And the etiology is thought to be continued cellular damage or robust immune response and cytokine production, which continues to cause the symptoms. And if we were to look at how acute to post-acute COVID progresses, the most common symptoms these patients, when they come to you in clinic, present with hair loss is a very, very common symptom that most patients present to us. And they just can't understand why they are losing hair. Chronic kidney disease, thromboembolism, palpitations, chest pain, cognitive disturbances, especially brain fog. And if I were to shorten that list, the most common things that people come with is a cough, shortness of breath, and fatigue, palpitations, brain fog, or not quite remembering what they're talking about, or having problems concentrating at work, pins and needles, multi-system symptoms, etc. And twice as many patients with long COVID report a relapse of symptoms that they had when they first had COVID. And then you can divide it again into multiple systems. But if I were to go with pathophysiology, I really like this slide because pathophysiology-wise, long COVID or post-COVID-19 syndrome is thought to be because mainly of 2 reasons. One is long-term tissue damage, and the one is unresolved inflammation. So for long-term tissue damage, cardiologically, patients can present with symptoms of chest pain, palpitations, tachycardia, orthostatic intolerance, or a bit of hypotension. Pulmonary-wise, cough and dyspnea are quite common. Neurologically, cognitive impairments, headache, depression, anxiety, insomnia, persistence of anosmia and fatigue also are there. And with unresolved infection and persistence of virus is what it is thought to be, can actually give to chronic fatigue syndrome, myalgia, fatigue, and joint pain, which were also seen with MERS viruses as well before. And gut dysbiosis can lead to a bit of loose motions and gastrointestinal and neurological symptoms. And sometimes, because of unresolved inflammation, a few patients may develop increased autoimmunity, leading to joint pains, headaches, cognitive impairments, and orthostatic intolerance. And it is presumed that 1 in 20 people are likely to suffer symptoms lasting more than 12 weeks. And 10% of those in the younger age group of 18 to 49, and nearly double that in elderly. And those with high BMI and female gender are supposed to be more susceptible to having long COVID symptoms. And this is quite in the pulmonary OPD, we really get a lot of patients who've had post-viral symptomatic asthma, new onset COPD-like symptoms, and their pulmonary function test shows small airflow obstruction quite a lot, worsened interstitial lung disease, and bothersome palpitations. So why are they affected? As I just discussed, we really don't know for sure, but it is presumed that it could be because of persistent viremia, inflammatory response increasing. As Raja said, it could be reinfection, co-infection, but again, unless we have the genetic prototype, we wouldn't really know if it was that. Deconditioning and post-traumatic stress add significantly to long COVID syndrome symptoms, and we must keep that in mind. And there's a very nice study in BMJ 2020, how to manage these patients in the outpatient department, and you may look through it, and that's why I put this ahead. Now, coming to mainly the post-COVID pulmonary complications that we see in our OPD, most of them will present with one of these, and I will take one by one. So a lot of patients who have had severe COVID and have been in the intensive care unit, the most common sequelae that is in the ICU is they have difficulty in ventilator weaning. And when they are able to be weaned off the ventilator, nearly 6 to 30% of those will need prolonged non-invasive ventilation, and nearly half of these will have chronic oxygen dependence and may need to go home on oxygen. And nearly 40% of these will persist to have dyspnea, decreased exercise capacity, and hypoxia, and this may persist nearly up to 6 months in 25% of patients. And CT findings, as all of us have seen in the entire period, that even 3 months after discharge, nearly half of the patients may have ground glass opacities and fibrotic damage persisting, and their resting saturations might be good, but I'll talk to you what happens, how we can show whether that is just a radiological finding or if it is important at all. And in those who have succumbed, their lung autopsies have shown that these patients who had very severe disease actually have endothelial injury and microangiopathy, and pulmonary micro and macro thrombosis in nearly 20 to 30% of patients. And the mechanisms thought in these patients is supposed to be viral invasion of alveolar epithelial and endothelial cells, and viral independent mechanisms being immunological damage and perivascular inflammation. Let's come to the first symptom, and that is chronic cough. And a lot of us face it, and with or without CT changes, with or without them having had severe COVID. And what are the causes of chronic cough? There are lots of patients who do not have any underlying disease, but do have chronic cough. And what has been shown is that 80% of the work of breathing is done by the diaphragm. And in COVID, especially after illness, there's general deconditioning of the patient, and the breathing pattern can be altered. And that reduces the diaphragmatic movement with greater use of neck and shoulder accessory muscles. And cough control is something that really helps in the patient who does not have an underlying cause that can explain the cough. And in these patients, telling them to do breathing control for 20 to 30 seconds, followed by 3 to 4 deep breaths, and breathing control again for 20 to 30 seconds, followed by 3 to 4 deep breaths, and similarly again the third cycle, followed by huffing and followed by coughing if necessary, actually over a period of 5 to 7 days significantly reduces cough in many patients. And this is something we use in our clinic with some good benefit. Also, if their pulmonary function test shows small airflow obstruction or some lability, then inhaled steroids may help for a period of 4 to 6 weeks along with that. Obviously, if they have underlying airways disease, optimize their inhaled steroid levels. Ask them to stay hydrated, and sometimes in severe cough, and if there is secondary infection, they may need antibiotics and oral steroids as well. Breathlessness is the most common symptom, and as I'll show you that the patients who present with breathlessness, whether it is really important and whether it is actually causing VQ mismatch or not, can be unearthed by doing pulse oximetry at rest and after walking for 6 minutes. But many patients are so weak, they cannot walk for 6 minutes. The other two things are to do a 2-chair test. Dr. P.S. Bhattacharya has done a really good paper on it, or 3 minutes walking. And if they are frail and can't do that much, you can also ask them to sit and stand in one place for 1 minute. What you are looking for is if there is a fall in saturation of more than 3%, and that is significant. So in the post-COVID clinic, or when the patient has had COVID and they come to you, the one thing that you must and can do easily is a 6-minute walk test. As you will see in this patient who said he wasn't very symptomatic and baseline saturations were okay, and by second minute, they desaturate to 88% nearly. So 6-minute walk test unearths if that breathlessness needs to be reassured or whether that breathlessness needs to be treated. Coming to airways disease, we know that viral infections exacerbate asthma, but most meta-analysis and case control studies have shown that asthma is not a risk factor for long COVID syndrome. As in any viral exacerbation, optimizing inhaled steroids is essential. And if the patient is cooperative enough, then PEFR monitoring is recommended for at least 3 months post-COVID. And the studies have shown both in asthma and COPD that there isn't significant changes if you optimize their inhaled therapy. Coming to interstitial lung disease, which is a known comorbidity for severe disease and also for worse outcomes. Those who were hospitalized require increased oxygen support, most of us have seen, and those with ongoing organizing pneumonia actually should not be given just 5 or 10 days of steroids. They may require gradual withdrawal of steroids over a period of time. And these are the category of patients where antifibrotics use is justified if there is evidence of ongoing fibrosis. The entity which we see mostly in people who have not had interstitial lung disease but have persistent post-COVID ILD, they may continue to have organizing pneumonia, interstitial thickening, and they are very commonly commenced, as I see these days, on pirfenidone and nintedanib together. And sometimes a good radiological assessment is essential in most patients, as most will have no or minimal trace of fibrosis in 3 to 6 months' time. And there are good studies to show that persistent COVID-19 interstitial lung disease, corticosteroid treatment actually gradually reducing it over a period of time rather than adding antifibrotics will help, as this is one of our patients. You can see this was the condition. So on this, he was labeled as interstitial thickening, along with that some areas of organizing pneumonia. This patient was not given any antifibrotics, and 2 months down the line, this is the CT scan. So they will be left with sequelae, but not all of them require to be given antifibrotics. And if you were to compare the 6-minute walk test in 2 months' time, the baseline saturation initially was 93%, which improved to 97%, and desaturation level, which went down to 85%, was down to 93% only. So steroids alone. So radiological assessment of who should be given antifibrotics and who shouldn't be given is quite important. This is another one from a Chinese group initially, where they showed that also age has a significant amount of factor in patients who have severe disease. This is a 33-year-old male, again, who was given only steroids, and with critical pneumonia and ARDS and mechanical ventilation, both were on mechanical ventilation. This is a 33-year-old male, and this is a 69-year-old male. The 33-year-old male in 2 months clears up quite nicely, whereas the 69-year-old gentleman actually has fibrotic remodeling of his ARDS. So fibrotic remodeling, when it remains, will leave the patients with a lot of breathlessness and exertional dyspnea and desaturation. And in this category of patients, sometimes we are faced with how can we help this patient more? And is there anything more than just steroids? Do antifibrotics help? When do they help? I'm not sure we really have all the answers currently, but currently no fully proven options are available for the treatment of post-inflammatory COVID-19 pulmonary fibrosis. Although risk-benefit ratio should be assessed prior to use, prolonged low-dose corticosteroids may prevent remodeling of lung in survivors, and other treatment strategies are under observation. Let's talk about nintedanib and pirfenidone use and what is their rationale of use. So, do they inhibit viral infection or disease? It is really not described anywhere. Do they inhibit experimental acute lung injury? In nintedanib, it is not described, but pirfenidone literature does describe that it can inhibit acute lung injury. Do they inhibit IL-1 or IL-1 effects? Both do. Do they inhibit IL-6 effect? Yes, both do. So in patients who have severe disease and are having rapid fibrosis, not getting better with steroids, we do have a rationale to give nintedanib and pirfenidone where the patient's oxygenation and lung remodeling is concerned. And I think it'll have to be only on an experimental basis. Also, for how long and when to start, that is a question I don't have an answer to. I'm sure my other panelists will, and our moderator will have something to add to that. So depending on severity, if the patient has previous interstitial lung disease, treatment to be continued as before, continue antifibrotics in known UIP ILD. In post-COVID ILD, reducing dose steroids may be needed over weeks while monitoring saturation at rest and 6-minute walk test. And in all of these patients, pulmonary rehabilitation actually plays a major part. Not only does it help reduce breathlessness, it also helps reduce the other long COVID syndromes like fatigue, for example, shortness of breath, lifting of mood, etc. So pulmonary rehab must be recommended in all these patients. And respiratory follow-up algorithm for these patients should be, not every patient requires high resolution CT test when they come back to clinic, only and only if there is evidence of interstitial lung disease. If you suspect there could be a there could be a pulmonary embolism and they have raised D dimers, that's when you can do a HRCT test or a CT pulmonary angiogram. Otherwise, a chest X-ray, 6-minute walk test, pulmonary function test and diffusion capacity at 12 weeks is good enough. Coming to pneumomediastinum, I'm sure all of us who are sitting here have seen more pneumomediastinums in the last 2 years than we have in our entire careers. And some patients, very, very strangely, who have had severe COVID, been on the ventilator, got better, came back in 2 months' time with acute COVID-like symptoms, severe shortness of breath. And Dr. Ghosh will remember one of our patients who was also a doctor, had gone home, got better, and 8 weeks later came with high-grade fever, severe shortness of breath, and was found to have a secondary spontaneous pneumomediastinum. The mechanism is considered to be rupture of subpleural blebs, which is common in severe infection. Most recover with conservative management. However, these are the patients who, when they go home in remodeling and you find areas like this, these are patients where if they have severe cough, suppressing their cough sometimes helps. And that is something I have learned in the past 1 month, that people who have severe fibrotic changes and have enlargement and thickening of their airway walls, thinning of their airway walls, severe cough actually sometimes presents with sudden chest pains, and they have spontaneous pneumomediastinum. As you can see, sometimes these pneumomediastinums are actually missed if you do just a chest X-ray. But if a patient comes back saying that they have sudden severe acute chest pain in the central chest pain after coughing and shortness of breath and desaturation is not being explained, sometimes a CT screening shows you a very small pneumomediastinum. The good thing about these pneumomediastinums is that this is entirely conservative. Even this pneumomediastinum in a young patient was only 27. We did nothing. He was desaturating down to 85, 86%. We just gave him oxygen, antitussives, and rest, and he recovered from that. But sometimes these patients will progress and they will have the pneumomediastinum will lead to pneumothoraces. This is one of our patients who was a young chap, but he had bilateral pneumothorax, and he was given up for good. He was sent to us that can you do something bronchoscopically to clip because he's not a surgical candidate. We spoke to our surgeon and our surgeon said, no, we'll take this case up. And this patient is actually better now. He's off oxygen. He comes walking to the clinic. So please don't give up on patients who have secondary spontaneous pneumothorax, because not everyone is going to be able to afford a lung transplant, and not everyone should be just left on oxygen and left there. Do speak to your surgeons. Sometimes we can also try bronchoscopically, but so far, I'm not sure how many have been successful. So pneumothorax in small asymptomatic apical pneumothorax, conservative management, more than 20%, obviously intercostal chest strain. If there's a persistent air leak, surgical evaluation is definitely recommended and in good hands with good benefit, as I showed you in that case. In inoperable cases, bronchoscopic attempt at closure if the patient tolerates it, and in bilateral severe disease, lung transplant remains an option. So this is the story of a lady who was 32 years old, who basically came to hospital. This was early during when we did not have antibody tests. We only had RT-PCR tests. And this lady came into the emergency with severe shortness of breath and clinically had bilateral pleural effusion. Her COVID RT-PCR was negative and her TROP-I was positive with anterior wall changes. The cardiologists took her up and with echo showed generalized wall hypokinesia and an ejection fraction of 45%. She had no risk factors for ischemic heart disease, and she was thin, of a good BMI, with no other risk factors for having ischemic heart disease. The when she had a CAG, her CAG was clear. So they diagnosed it as an acute MI, but CAG was clear. She was treated for heart failure and sent home. 5 days later, she came back again with severe shortness of breath and was again in heart failure. And this time, an IgG antibody was done, COVID IgG antibody. She was RT-PCR negative, and COVID IgG antibody was done, which was positive. So this was most likely a myocarditis or a cardiac involvement following mild COVID infection, which she must have had at least 3 to 4 weeks before at home. So we do encounter many such patients who have primarily had COVID alone and will present with heart failure picture, and a great deal of detective eye will be needed for suspecting and guiding, as 3-month mortality in these patients is very, very high. Pulmonary embolism has already been discussed, that post-COVID management of established PE remains appropriate anticoagulation by warfarin or newer oral anticoagulants for at least 3 months. Because it is a hypercoagulable stage, those who have persistent explained shortness of breath, PE must be suspected and D-dimer testing done appropriately. Those who have severe disease and are poorly mobile, then when you're discharging them, 28 days of DVT prophylaxis is recommended, but nothing more than what you would do for any other disease. And follow-up for these patients is recommended at 4 to 6 weeks with a 6-minute walk test and a chest X-ray. CT not routinely recommended. At 2 weeks, if they have been admitted with severe disease, a CBC, CRP, and a D-dimer is appropriate. A lot of patients will have persisting transaminitis, and if they did have, then an LFT at 2 weeks is also indicated. And the BTS recommends management of pulmonary sequelae as respiratory follow-up, definitely do a psychiatric assessment of the patient, and thromboembolic sequelae diagnosis if is present. And based on the severity of acute COVID, the level of care received, chest X-ray of all at 12 weeks, and we have discussed the rest. Corticosteroids may be beneficial in a subset of patients with post-COVID inflammatory lung disease, and for how long, that will have to be individualized based on the treatments post-COVID sequelae. And antifibrotic therapies are given only in the clinical trial setting for now. And no long COVID syndrome talk can be complete without talking about an interdisciplinary management, and depending on whether they have dyspnea, whether they have neuropsychiatric symptoms, primary care, renal condition, interdisciplinary management is definitely required in a lot of these patients, and it helps. So to conclude my talk, long COVID syndrome may be seen in 10% of patients, maybe more. Cough, shortness of breath on exertion, and fatigue are the most common symptoms patient present to us in the OPDs. Patients should be advised to monitor 6-minute walks at home. It helps unearth VQ mismatch early. Asthmatics must continue inhalers regularly post-COVID, and persistent post-COVID interstitial lung disease with predominant ground glassing may require longer courses of steroids under strict follow-up. Antifibrotics must not be routinely prescribed, and pulmonary rehabilitation is recommended in all post-COVID symptomatic patients. Thank you for your patient hearing.
Thank you, Sushmita. It was very informative. And is there any questions, or I may just ask a couple of questions? One is in the post-COVID scenario, you mentioned the British guidelines that a subset of patients with post-COVID will require steroids. Now, if this, suppose we see patients who comes after 14 days or 21 days of quarantine, have gone home from the hospital or has been treated at home, they come with symptoms and you do a assessment and 6-minute walk, and they are desaturating. Now the CT is there. Do you have any radiologic, apart from radiological ground glass opacities, is there any other criteria which will enable you to assess the situation and put them on steroids at 14 days or 21 days, although there has been a gap, but they come back to you after 14 days quarantine? Do they need steroids, and which subset of these patients will need steroids apart from the ground glass?
I'll need you to please repeat the question because the audio went off completely. I couldn't hear it.
Okay. Right. Now, can you hear me?
I can hear you now.
Yeah. Now, mentioned the guidelines of BTS where they mention clearly that a subset of patients will require corticosteroids. We are seeing patients who come to us after 14 days or 21 days of quarantine. They have been in the hospital or some have not been in the hospital. And then after 14 days, they come to you, they are desaturating, 6-minute walk test or whichever. And at that point of time, what are your criteria of putting them on steroids if they need steroids? Because this is somewhere, we are seeing more of nintedanib and pirfenidone rather than wisely used steroids in these situations.
Yes, that's a very good question. I think you, I, Parthuda, Raja, all of us in our OPD see these patients on a regular basis. And most of the time, we are actually taking them off the antifibrotics. So a lot of these patients will come with, most patients come with CT scans in hand. And there, if there is persistent ground glassing, if the patient is dyspneic at rest, 6-minute walk test is the only test that I make them do. And on 6-minute walk test, if they are desaturating and there is persistent ground glassing on their CT scan, then I would definitely start them on steroids. I usually start them on 1 milligram per kg body weight and reduce it over a period of 2 weeks and review them again to see how they are, to see whether that needs to be further reduced or not. Most of these patients, actually, what I have found in OPD, will do well if you reduce the steroids over a period of 4 to 6 weeks. But they do need to come back to clinic often. If not, then monitor their 6-minute or 2-chair test at home and inform us how they are doing. So, but I usually reduce them every 7 days.
Right. And 4 to 6 weeks is adequate.
Yes.
If they have organizing pneumonia-like picture.
That's right.
Right. Fine. That's wonderful. And the other thing, I also went through the Nature's article which you mentioned on the post-COVID a couple of months back. And there they mentioned the post-traumatic stress disorder. We are seeing a lot of these patients also who are symptomatic, yet their saturation is normal. Even 6-minute walk test is normal. Even a PFT with DLC is normal, not too bad. So that's something also we need to, I don't know how to approach it. I haven't referred them to a psychiatrist, but I think that should be also part of the multidisciplinary. Now, any other questions from the audience? Two wonderful talks. And
there are questions in the, there are questions already.
Can you ask these questions, please?
Yeah, how to follow raised D-dimer and role of NOx on discharge and duration of NOx. That is one. Yes. So if you pick up that, I can
in the NOx segment, is rivaroxaban is the only one, or you can use apixaban, or you can also use the others, like the direct thrombin inhibitors, dabigatran, which is more commonly if they at all use NOx.
But the question is how to follow this D-dimer. How frequently would you test it? How long should you give NOx? I think that is the main crux of the question.
I think most of the studies that have shown is that you really don't treat a number. If a patient is high risk for pulmonary embolism and has D-dimer levels which are very high, then you give them the NOACs for 28 days. And if they are mobile in between, then you don't really check after that. But having said that, they are also correct. Sometimes some of these patients are there whose D-dimer continues to remain high. But if they are not desaturating, I'm not sure whether there is any rationale for continuing it beyond that.
Yeah, there is no strong evidence of post-discharge anticoagulation, thromboprophylaxis, unless the risk factors are high. Yeah, next question.
There is another question. In patients receiving long-term steroids, what are the factors to look upon? Is there any role of prophylactic antibiotics?
I think Sushmita should answer.
Yeah. So long-term steroids is how long are you talking about? If we are talking about 4 weeks, 4 to 6 weeks, and the patient is immunocompetent, then I don't think there is any rationale for it. But if there are patients who have interstitial lung disease, have had an acute exacerbation, and will need to be reduced over a period of time and need to stay, then there is definitely evidence that you should be giving them prophylaxis with thrice weekly PCP prophylaxis to be given for them.
We have another question, that is the role of tofeptinib in severe pneumonia with COVID.
Can you repeat the question, please?
Role of tofactinib in severe pneumonia with COVID. By
Tofactinib.
Parvati Nand.
Raja can answer.
I think Raja has gone to Sharjah probably.
Yeah.
He's left.
There are other questions to how to follow raised D-dimer and note. So that's over.
That's over. Yeah.
Specific indications and contraindications of antifibrotics in post-COVID patients. Please comment.
I think that was that was discussed in the talk. But anyway, if you want to highlight,
already discussed. But I think there is a role of antifibrotic also. We are getting it. Probably we'll get it cleared soon because expert opinion is going to be published very soon.
Yeah.
In patients receiving long-term steroids, what are the factors to look upon? Is there any role of that's over? Role of steroid-sparing agents to treat post-COVID ILD? Is there any scope?
Only if there is interstitial lung disease from before. So my only concern is that we treat post-ARDS or post-inflammatory interstitial lung disease the same as, autoimmune interstitial lung disease. I think the two are different, and giving immunomodulators there is, I don't think there is a rationale there. But if somebody has connective tissue disease ILD and they have been on immunomodulators before, or they are on steroids and going to require longer, there I think immunomodulators are indicated, but not for post-ARDS ILD.
Right. Any other question? Parthoda, any other questions?
No, we have got a real world experience of treating the post-COVID situations, especially lung lesions. I'm not going to disclose them right now, but soon I will, in any of the next Pulmocon module, as soon as it is compiled, I will disclose. I think there is a selective role of antifibrotic in certain subgroup of patients, not in everybody. So I'm just awaiting my data to be pulled and statistically looked into.
Well, a few of my patients have done pretty well on antifibrotics. I don't know.
That is why I brought that paper I brought, the role of perfenidone and perfenidone and nintedanib. Both have anti-IL-1 and anti-IL-6 activity. And there is definitely a subset of patients where they are still requiring a lot of oxygen and have a horrendous looking scan. They do well if you give them antifibrotics in addition.
But one thing I can tell you, I have looked, whatever I have experienced statistically, if you treat or don't treat, or if you treat with any damn thing, we have given multiple agents singly or in combinations, everyone improved, almost everyone improved. So there is a natural course of improvement in post-COVID scenario, but the pace of improvement is different. It is different with steroid, it's different with antifibrotic, it is different with doxycycline, which I have tried. And what I feel that this pace will actually determine the future indication of antifibrotics or steroid in post-COVID scenario. And one more important issue to my mind is that if you follow the course of SARS-1, about 5% of the patients have got long-term sequelae. Even after 15 years, they have got some lung lesions left with. So if you take the total number of COVID-19 patients, that 5% bulk will be quite enormous. So I think we must be looking forward to find an answer to that we shouldn't make that 5% remain 5% or more. We do not know what will happen to them, but we'll try our best to reduce it as best as possible.
Well, very good. Now Raja is back.
Raja has joined.
You're back from the stadium. So I want to ask you one question before we wind up. Any take-home messages for us regarding COVID and pregnancy? A pregnant lady comes with bad COVID or some mild disease. Any change, or is it the same treatment?
So I think there is evidence that the antibody cocktail can be given to pregnant women. It's not that the trials included pregnant ladies in the trial, but I think the hypothesis is that it should be safe in pregnancy, which is why it's been used in pregnancy. I mean, it's there in the literature, but also I know of people, not myself, but other colleagues in the country who've used it in pregnant women. Molnupiravir, we don't know about safety. In influenza, it's not a drug that should be prescribed in pregnancy. So you would extrapolate the same evidence in patients with COVID. I don't think you can give that to pregnant women. I think inhaled budesonide would be a very important drug in mild COVID, because we know from our asthma data that it's a safe drug in pregnancy. So that's one drug that I would definitely use. So, I mean, that would be my sort of algorithm. I would go between inhaled budesonide and maybe the antibody cocktail in patients who are pregnant with mild COVID.
Excellent. Okay.
There was one more question for Raja. The role of tofacitinib in severe pneumonia with COVID.
I think the data about tofacitinib, Parthoda, is extremely dodgy. I don't think there is data to support its use. So I know of a few. I've never used tofacitinib in COVID myself, but I know of colleagues who have in few numbers. We are desperate in severe COVID because aside from steroids, there's almost no drug which is evidence-based in all of severe COVID pneumonias. So that's why we keep using drugs like these. But I wouldn't advocate using tofacitinib given the data that we have in COVID today.
Yeah, fully agree with that, yes. I think since there are no more questions and the talks were very, very informative, thank you both the speakers. We have been very, not only in time, but at the same time, all the important messages were very clear and very, very pertinent. So I think if Dr. Parthoda agrees, then can we end the session?
But I have a small message to all my
yes.
participants that next week we are going to deal with radiology and MRI. So with lung diseases. So those who are interested, they may join. I have tried my best to get the best possible faculty for the discourse. And before we wrap up, from my end, I wish to convey my regards and heartfelt thanks to the faculty today, including yourself, and my revered audience also. So it's up to you to close now.